Great, so we're going to get started now. Good morning, good afternoon, good evening. Welcome and thank you so much for joining us for today's webinar, Links Grantee Progress and Achievements. My name is Marissa Levy and I am the Program Assistant for the Links community here at Resolve to Save Lives. To date, Links has awarded 42 grants in 35 countries. The grant funding has been divided among governments and civil society organizations with the goal of advancing cardiovascular health programs in low and middle income countries. These grants are awarded to programs that focus on improving heart health, from reducing the burden of high blood pressure to reducing salt intake and eliminating trans fat. To learn about our Links grantees and the work they are doing, go to the Links website, click About, and then Grantees. This page will show the world map of where all of our Links members and grantees are working and the profiles of different projects. Today's webinar will highlight the accomplishments, challenges, and takeaways from 3 of our Links grantees, one from each focus area, one from sodium reduction, hypertension control, and trans fat elimination, respectively. These grants have been doing amazing work in Sri Lanka, Cameroon, and Jamaica. So first, a few agenda for today. We'll be going through some introductions, setting the norms, then our presentations from our 3 Links grantees, a Q&A session to follow, and a wrap up. So first, some housekeeping items to discuss before we dive into the presentations. Each presentation will be about 10 minutes long. We recommend jotting down some notes if you have any questions throughout the presentations, as we will be holding a Q&A session after all 3 presentations are finished. We encourage participants to use the Q&A button in Zoom and not the chat button to ask questions. The Q&A button is located at the bottom of your screen. For the duration of this webinar, participants will be muted, but you will have the option to type in questions for the Q&A portion of the presentation. Lastly, the webinar is being recorded and will be posted on the Links community website. Now, the order of the presentations will be: first, the WHO Sri Lanka Country Office; second, Cameroon Baptist Convention Health Services; and third, University of Technology, Jamaica. Now, I'm excited to introduce our first guest speaker and her project, Dr. Nalika Gunawarden, a National Professional Officer for Non-Communicable Diseases and Health Systems at the World Health Organization Country Office, Sri Lanka. She will present on the Links Grant project on supporting the government of Sri Lanka to implement the National Salt Reduction Strategy 2018 to 2022. This project aims to provide policy and technical support to the Sri Lankan government for engaging with the food industry on salt reduction and for the development of food standards that promote healthy eating. These activities support the implementation of the country's National Salt Reduction Strategy. I'll hand it over to Dr. Gunawarden to begin your presentation. So take it away, Dr. Gunawarden.
Thank you very much, Marisa. Good morning, good afternoon, and good evening. I thank the organizers for the opportunity to share the achievements and the challenges of our support to the government of Sri Lanka to implement the National Salt Reduction Strategy. Next slide, please. Sri Lanka is an island nation in the Southeast Asia with a population of 22 million. The NCD burden is high, with approximately 80% of the mortality being due to NCDs. Salt consumption surveys has repeatedly shown that the average salt consumption to be more than double the recommended amounts. Guided by the National NCD Policy and the National Multisectoral Action Plan for the Prevention of Control of NCDs, the National Salt Reduction Strategy in Sri Lanka was developed in 2018 in line with the WHO Technical Package of SHAKE. The grant activities focused on educating and changing the behavior of people to reduce salt intake, developing food standards and guidance to promote healthy eating in different settings, and engage in the food industry towards reduction of salt content of food through reformulation. Next slide, please. I've summarized the key accomplishments under each theme and will run through them. Next slide. The communication package we developed to change the behavior of the public to reduce intake of salt was based on a survey among adolescents, adults, and owners and cooks of the food premises. We did this to obtain an insight onto the specific issues related to sources and the reason for the high salt food intake. Next slide. The campaign is developed in 2 local languages, Sinhala and Tamil. The main messages are on salt and ill health and the upper limit of salt per person. The campaign is branded, proposing a salt formula, indicating less salt for more health and more salt for less health in local languages. Next slide. Another activity that was supported to change behavior was a social media campaign on interpreting the front of pack labels. The government of Sri Lanka enforced a regulation in late 2019, mandating all packaged foods to contain a color-coded label indicating the content of salt, fat, and sugar. Our focus in this campaign was assisting the public to interpret the combinations to make healthy choices. Next slide. In Sri Lanka, the great majority still consume home-cooked food, and traditional food items contain high salt. In this background, we conducted a national low salt cooking challenge to increase the awareness about the importance of low salt cooking and on alternative flavorings to salt in the common local foods. Actually, we conceptualized this based on an Indian experience shared at a community of practice session organized by the Resolve earlier. The challenge invited interested groups and was conducted in 2 virtual and 1 blast on-site rounds. The selected groups were trained and guided by the Chef Guild of Sri Lanka. The final event was done under media coverage and the First Lady attended. An e-recipe book is being published in local languages. One proud accomplishment is the decision of the Chefs Guild on including a low salt cooking as an item in their annual Southeast Asian cooking competition in the future. Next slide. Moving on to the activities to promote healthy eating in different settings, the accomplishments are as follows. Next slide. Sri Lankan government hospitals serve cooked meals to warded patients free of charge, and the canteens in the hospital premises serve patients and visitors. In schools, the canteens are available in only 1/3 of schools and is a place where food can be purchased by students and teachers. The landscape assessment we conducted on food procurement and servicing standards at hospitals and schools under the grant activities revealed several official directives and standards to be already in place, but not fully implemented. Thus, we developed renewed, simplified guidance to promote healthy eating at hospitals and schools with a framework to monitor the implementation. We are pleased to announce that the NCD Advisory Board of the Ministry of Health has approved the guidance to be implemented in the government hospital and also had requested the private hospitals to take on the guidelines. Next slide. Advocacy and technical support to engage with the food industry is one main area of value of the grant activities. Next slide. As informed earlier, the government of Sri Lanka implemented the regulation on color coding of packaged food for content of sugar, salt, and fat in 2019. Through the grant, we designed and supported a label survey and collection of sales data of 4,239 food items during the first 6 months of the grace period And this we did to be used as a pre-assessment of an evaluation of the effectiveness of the label regulations in the country. As shown here, the main findings were that 1/4 of the items contain the label within the first 6 months of grace period itself, and a great majority conform to the specific requirements of the regulations. Next slide. Using the images collected for the survey, we supported an online repository, which is open for any interested person to access and use. Next slide. The grant supported to reduce salt content of commonly consumed foods through reformulation, but as a stepwise process guided by a team of Ministry of Health officials and food technology consultants. The completed steps are an advocacy meeting with the key chain restaurants in the country to get their buying in to contribute to the national aim voluntarily. Next slide. Upon consent of these key restaurant owners, we visited the restaurants to collect 250 samples of commonly sold bakery and food items and analyze them for salt content. As shown, the salt content of each food item varied very much. Next slide. Of the foods, the expert group selected bread as the item to be targeted for reformulation in Sri Lanka, as it is the most consumed out-of-home produced food item in the country. And also it was found to contain more than 50% of the recommended upper limit of 5 grams per day per person of salt, which means if a person consumes half a loaf of bread per day, which is not uncommon in Sri Lanka, that alone will give them the 50% of the upper limit, recommended amount of salt per day. So these were the basis for selecting bread to be targeted for reformulation. And the targets to achieve, the targets that was designed by the expert group was to achieve a maximum salt level of bread to 0.36 per 100 gram in a stepwise manner over a period of 1 year. And this was based on the WHO global sodium benchmarks. The advocacy material to engage with food industry to agree on this voluntary target and the training manuals to the bakers are completed, and the implementation is planned by the Ministry of Health in 2022. Next slide. Yes, this is what I explained, the maximum target. So the achievements I described can be attributed to the support of Ministry of Health as we align the grant activities to the National Salt Reduction Strategy, and to the fact that the work was guided by a technical working group appointed by the Ministry of Health. That was key to our success. Also collaborating with the main stakeholders and the ready technical guidance by the Resolve to Save Life for the other facilitators. COVID pandemic and related restrictions affected the timelines of implementation of our grant activities by distracting the attention on other health matters. It also disrupted hospital functions and enforcement of food regulations, and also our engagement with the food industry. Plans are underway to continue the work in the coming year, specifically the support to evaluate the effectiveness of the front of pack label regulation and the implementation of target for salt content in bread. Next slide. Yes, again, I thank for this opportunity and the support by the Resolve to Save Lives, and thank you everybody for your attention.
Thank you so much, Dr. Nalika, for that wonderful presentation. I am now going to hand it over to our next guest speaker, Dr. Epi Najume from Cameroon Baptist Convention Health Services. Dr. Epi Najume is a physician and the general supervisor of the NCD Prevention and Control Program at the Cameroon Baptist Convention Health Services. Dr. Najume will present on the LINKS grant, standardizing the quality of hypertension care in 5 health facilities within the Cameroon Baptist Convention Health Services. CBC Health Services aimed to standardize hypertension care and specialist services in 5 main health facilities to develop an electronic health management information system and improve patient retention and care through clinics and community-based follow-up. CBC Health Services also worked with the Ministry of Public Health to endorse this protocol nationally. Handing over to you, Dr. Najume, for your presentation.
Thank you very much, Marisa. Good morning, good afternoon, good evening, everyone. I will just go on to the presentation. Next slide, please. For the presentation, we'll follow this out. Next slide, please. So our project was principally based in 5 facilities of the CBC Health Services located in 5 different regions. And it ran from 1st of April 2019 to August 31st, 2020, with a focus on hypertension control. And specifically, we aim to standardize the quality of hypertension care, to develop a drug and dose specific protocol following the HAP package, and to advocate for this protocol to be used nationwide. Next slide, please. We started off by establishing a steering committee and a multidisciplinary team of experts for the CBC Health Services, the Cameroon Cardiac Society, the Ministry of Public Health, comprising cardiologists, internists, general physicians, nurses, public health physicians, and researchers. Now, we conducted a baseline survey to have a sense of what was going on when it comes to guidelines and protocols for managing hypertension. In the survey, we wanted to know what protocols were available at the health facilities and whether doctors and consulting nurses use these protocols, the prescription patterns, and for those who admitted not using the protocols, we also asked why they did not use the protocols. We had, after that, we conducted 3 panel meetings, initially to introduce the project, present different versions of the protocol, and after which and a consensus version of the protocol was agreed upon, and this was piloted in 5 of these health facilities. Before the pilot began, we trained nurses, trained 31 general physicians, 33 nurses on how to use the protocols. And after the pilot phase, we conducted the inline survey and submitted the protocols to the Ministry of Public Health for endorsement. Next slide, please. Can we go back to the previous slide? I was going to mention that the CBC Health Services has been practicing task shifting, that is shifting of key functions from physicians to nurses who are more widely available, especially in the rural settings, despite the fact that there's no public policy on that. And so nurses played a very crucial role in terms of during the pilot phase. And I would also like to note that we, at this period while we're piloting the protocol, we had an agreement with Novartis through their access initiative to ensure that the medicines that were mentioned or were indicated on the protocol were available at this time. Now, on this graph, we can see results of the baseline and end line when we ask about the availability and use of various protocols. And you can see that there were 8 different protocols in use at the time. And out of these 8 protocols, you would imagine there were lots of variability in terms of description patterns. But at the end line, you would see that one of the protocols labeled others was mainly being used, while the use of the others decreased substantially. And this order is the new protocol that we implemented. That shows some level of uptake. And when we looked at the question on why people admitted not using the protocols were not using them, the most common response, or the most frequent response, was non-availability of the protocol in the facility. For those who admitted that there were protocols, there was some kind of confusion of the many types that existed, and some indicated that there were no medicines, or medicines and doses or laboratory tests were not specified in these protocols. Next slide, please.
Dr. Najume, your audio is a little fuzzy. Do you mind maybe turning yourself like on mute and then turning it back off mute to see if that will fix the problem?
Is this better? Is it better?
It's still a little fuzzy.
Probably, maybe I'll just, I'm not sure why, maybe it's the strength of the connection. I'll try to, Is it better now?
Yes, that is better now.
Okay, thank you very much. So on this slide, we have the protocol. This is the current version of the protocol that has been submitted to the Ministry of Public Health. And as you can see, we followed the approach based on hypertension grades, mentions medication names, specified the doses, and included a titration schedule. We equally included laboratory tests, basic laboratory tests, and complementary tests that can be done at the baseline and conditions for referral. And on the far right is a panel for lifestyle modification advice. Next slide, please. On this slide, we try to show a few of the results. We realized we noted at the end in the survey that systolic and diastolic blood pressures were better at the end line compared to the baseline, and that patients whose management followed the protocol, the new protocol, were more likely to have controlled blood pressures. And we noted a significant difference of blood pressure, systolic blood pressure, between the initiation of the protocol and the end line after 6 months of implementation. We also evaluated the use of the protocols at different months, comparing those who were on the new protocol and those who were on regimens that were different from what was on the protocol. And we equally found that those whose regimens were directly followed the steps in the protocol had better control of blood pressures, while all the other factors, including lifestyle modification and adherence counseling, remains constant. You're right. Next slide, please. Here are a few pictures of the activities, including the panel of experts meetings, training of general physicians and nurses, and also community health workers. We trained community health workers
to go into the communities and encourage patients who have been lost to follow up to bring them back to care. Next slide, please. After securing all the necessary permits and authorizations and establishing the steering committee and expert committees, we submitted reports to resolve to the Ministry of Public Health and to the CBC Health Services Institutional Review Board. We equally publish articles of these activities in NCD program newsletter and on social media. Next slide, please. There were lots of lessons to be learned that we learned from this project. The first one is the critical role of WHO HART package in establishing a successful control program, especially through the development of a drug and dose specific protocol. And we also noted that having a multidisciplinary team of experts that are based on the ground to offer technical support and guidance was indispensable. We also made use of patient medical records to generate the context-specific data that would provide a strong base for the protocol. And we learned that simple algorithms standardize care, improve outcomes, and can potentially save lives. As challenges, well, we are looking at the challenges mostly as opportunities or areas of further where we need, areas in which we need to work further. We need to train more staff, especially nurses, to effectively task shifts and improve coverage of hypertension care. We need to equally define the protocol implementation plan with monitoring and evaluation aspects. This will allow us to conduct impact assessments, identify gaps, and bridge these gaps in real time. Next slide, please. I'll be delivering a similar presentation tomorrow at the Yaoundé Healthcare Conference in Yaoundé, the capital of Cameroon. And this is the first ever NCD conference in Cameroon. And we have the opportunity to share the outputs of this work. And equally, we are working with the Ministry of Public Health to incorporate this protocol into the National Cardiovascular Disease Guidelines, which is currently under development. And we're working on manuscripts that highlights the protocol development process and the survey findings. Next slide, please. We'd like to thank, on behalf of the project team, to thank Resolve immensely for the technical and financial support, without which this project would probably only remain as a dream. We equally thank the Ministry of Public Health, especially the Subdirectorate for NCDs, and we acknowledge our nurses and physicians who participated in this pilot phase and the leadership of these health facilities, and everyone else for your kind attention. Thank you.
Thank you so much, Dr. Epi Njume, for that wonderful presentation. Now we will hear from our last presenter, Professor Fitzroy Henry from the College of Health Sciences, University of Technology, Jamaica. Dr. Fitzroy J. Henry is a professor of public health nutrition in the College of Health Sciences and the School of Public Health and Health Technology at the University of Technology, Jamaica. And he will present on the LINKS grant assessment of trans fat in Jamaica food system. The College of Health Sciences assessed the amount of trans fat in spreadable fats, edible oils, cookie products, snacks, and fast foods from transnational and local restaurants and bakeries across Jamaica. The goal was to lay the groundwork for the development of trans fat national standards and policy in Jamaica. So I will hand it over to Dr. Henry, and you want to share your screen, correct?
Yes, I do.
Okay, so I will stop my share and you should be able to share your screen now.
Thank you. Good morning, Marissa. Good morning, colleagues. Good afternoon, colleagues. Good evening, colleagues, I think as well. Happy to be here sharing with you our experience with the Links Grant project. Are you hearing me well?
Yes, we can hear you.
Wonderful, thank you. All right, let me go back to 2007. In 2007, the heads of government of the Caribbean community, we call CARICOM, came together in Trinidad, one of our island states, to address the issue of non-communicable diseases. It's a landmark meeting. It's the first time the heads of government anywhere have come together to focus on NCDs. The only other time heads of government came together was on AIDS. So it was a landmark occasion in 2007, and they came up with several declarations. And one of those declarations was the elimination of trans fat from the food supply in the Caribbean community. Well, 12 years later, Links came to the rescue because nothing really was done in terms of trying to assess the amount of trans fatty acids in any one of our country's food system. So we are very pleased that Links project came and not attempted to, but they supported the assessment of trans fat in our, it's hell of a thing when you're consuming foods, you go to the supermarket and you don't know what you're putting into your mouths. So what I want to share with you is our assessment of trans fat in commonly consumed foods in Jamaica. Because we are using the gas chromatography, we can look at the entire fat profile, including saturated fats and others. So for 296 commonly consumed foods in Jamaica, the objective was to determine the concentrations of fatty acids. So the results were reported to key stakeholders, and I will show you the details in a while, and then some implications and challenges. And then I will talk about the next steps in terms of education, reformulation, regulation, and monitoring. So the focus was trans fat elimination, and it was really to look, influence policies and programs in both the public and private sector. We started in 2019, not with the grants project actually. We actually got support because we didn't have the equipment at that time. So we got support from IDRC in Canada, and they were able to strengthen the labs in Jamaica. And this was one of the drawbacks why for 12 years we couldn't do anything. We didn't have the resources. So IDRC, through a fan project, strengthened the labs in Jamaica, and then Links project helped us to do the analysis of activities of food items. So we got this equipment, we did the training of several staff, and then COVID came, which disrupted the lab functions and also staff being able to come in and do the analysis and so on. But as you know, it's a simple method where you have glass going into the column, and you put in the sample, and we call it the oven, and it basically puts out the printout of the different types of fats that we have in that sample. So what did we find? When we looked at the different food categories, Marissa told you some of the categories. I'll go through them and show you the amount of trans fat that was found in the different food categories. The highest, and I'm going in descending order, the highest was in confectionery, and you see that how high it was. the cooking oils, desserts, spreads, snacks, dairy, condiments, fast foods, infant foods, breakfast cereals, baked goods, pastas, canned meat, and we found nothing, no trans fat in the canned foods or the beverages that we looked at. Now, this is just looking at the food categories with any amount of trans fat. And then what we decided to do is to look at these food categories where there was more than 2% of total fat of trans. In other words, the more concentrated trans fat based on the PAHO criterion. So we looked at those with high trans fat, those more than 2% of total fat, and we see dairy there, spreads, cooking oil, fast food, desserts, breakfast cereal, and so on. So we had quite a number of items. So for those that had any amount of trans fat of the 296, there was a 39.5, or call it 40%. In other words, 2 of every 5 samples that had some amount of trans fat. Whereas in this case, where the high trans fat levels is about 8% of the samples with what we consider the higher according to the PAHO threshold. Then, as I said, with the chromatography, you can look at the whole fat panel. We also had mono and polyunsaturated, but I'm just showing you the bad fats. We also looked at the saturated fat. So in addition to the trans fat, we see that the same items had quite a lot of saturated fat as well. And some that had very low levels or low concentrations of trans fat had high levels of saturated fat, because while trans fat is the target, we have to look at overall health and see exactly what is contributing to these non-communicable diseases. By the way, almost 4 out of 5 persons in Jamaica die from NCDs every year. So we see that even those with low levels had high levels, more than 30% of total fat with high saturated fat. So we also looked at the labeling that was on the food items. Of the 296 samples that we looked at, 175 of them, which is 59%, had a label with trans fat on it. And the labels that were trans fat free were 96% of those, that 175. In other words, 168 of them said it was trans fat free. Our lab analysis showed that those that said they were trans fat free, we had 38% with some level of trans fat and 8% with trans fat above 2% of total fat. So labeling is an issue. And of course, we had 7 of them that said that they had trans fat, only 4% of them, and they did have trans fat in them. So the health minister in May this year actually presented this at the sectoral debate in Parliament, and these results from the LINKS project were presented in Parliament in his sectoral presentation. And we are following up with a number of other activities since then. There were several webinars that I conducted between May and September this year, focusing on the results of this study. The Ministry of Health and Wellness, and then the webinars were distributed to various media houses for further distribution. The National NCD Committee and regional health authorities around Jamaica, there are 4 of them, where presentations were made as well. The Food Industry Task Force, which included members, this is run by the Ministry of Health and Wellness, but it includes members of the food industry so that they are aware of what we found. Universities, non-governmental organizations, have reformulation series, and when it came to trans fat, the results of this LINKS project were presented. And then I had a special meeting with LINKS staff and PAHO staff recently about the results, and there were several other entities asking for information, and I presented it to them as well. Currently, we are actually preparing a submission to Cabinet. Apart from what the minister presented to Parliament, we are presenting a Cabinet submission, not only on trans fat, but also on salt and sorry, on sugars. So there will be a Cabinet submission. In fact, we're working on it this week, that will go to Cabinet to get their attention, support, concurrence, and we are going to launch major activities hopefully next year. I have submitted a paper to the Pan American Journal of Public Health. It's now being reviewed, the challenge of bad fats to healthy eating in Jamaica. And because of some of the challenges I mentioned in terms of labeling, I'm looking at another paper right now, the potential and the problems of labeling trans fat in Jamaica. You know, we have a problem with labeling in the Caribbean. I noticed that my colleague from Sri Lanka was very proud of her front of package labeling that she was doing there in Sri Lanka. Well, recently in the Caribbean, through the private sector pushback, the front of package labeling in the Caribbean is stalled. We're still trying to overturn it, but it is stalled. I'll say no more at this moment on that. But it is something that we want to look at. So that paper will focus a bit on that. Education, the public is unaware of the health dangers of trans fatty acids, and we hope to do, with some resources, a lot of public awareness. Even the food manufacturers were unaware of the content, the trans fat content in the products that they are marketing. And that level of awareness also is on the way. Labeling is not yet mandatory in the Caribbean, believe it or not. You know, the labeling that we have on our food, the food fat, I'm not talking about front of package now, just the food labeling, the nutrition facts panel, that is not mandatory, it's voluntary even now. Of course, when they export, they have to put it on. So we have some level of labeling, but it is not mandatory. We're hoping to get that sorted out in May next year, which will include the front of package as well. And of course, for sustainability, we have the challenge of the cost of continued monitoring. It's quite expensive to do these analyses. We only have 2 labs now that were strengthened to do this trans fat analysis. And one of the challenges is, of course, to have that laboratory capacity increased in several of our Caribbean countries so that we can have this kind of information throughout our 15-member country CARICOM region. So we hope to do, I keep saying hope, right? Because it really depends on resources, but the healthy eating options in terms of grilling, frying, and baking, and what can be done, and how do we tackle trans fatty acids, and how we can use the mono and poly, the mix of soy, canola oil, coconut oil, and other oils. And of course, we're looking for a healthier food system. The Ministry of Health and Wellness has a right to know approach, and this will be key in our awareness approach. They say that citizens and members or anybody in Jamaica has a right to know what is in their products. Therefore, the labeling and this whole approach that they're using, we're going to piggyback on that in getting the trans fat results out. We'll have messaging on health dangers of trans fatty acid, but also on high saturated fat, as you saw in the slide. And we're also looking at high sodium and high sugars as well. The issue of labels, as I mentioned, is critical. And we'll have workshops with key stakeholders, including manufacturers. And we think that is manageable. However, informing consumers and the general public, that's needed, but that is costly. Reformulation, in those 296 samples where we found about 40% with trans fat, we have not informed the manufacturers exactly which ones had trans fat and how much up to this point. The Ministry of Health will do that while inviting them to reformulation sessions further down. But we found 52 companies having products with trans fat. We intend to target about 75, even though we only found 52 in this sample. We suspect, based on the pattern, that there will be about 75 companies that we need to target. And of course, there'll be training in the use of non-trans fat ingredients. We will certainly support government in passing the best practice trans fat elimination policy. We need to modify our existing food and food safety laws. And of course, you know, there will always be pushback, but we have strong evidence that can defend policy measures which may be subject to legal challenges, as we've seen in other areas. We have not set targets yet for elimination, and maybe colleagues listening to me can give me suggestions of what might be a reasonable time bound. Is it 2 years, 3 years? I know it depends on the intensity of what we want to do and the resources available. But we're now discussing among our group about what targets we should suggest for government implementation. The Ministry of Health and Wellness can use various mechanisms to communicate non-compliance with those targets. And of course, breaches of the compliance will attract appropriate penalties. So we're using training, reformulation, education, awareness, but of course, we also have penalties because the 4 out of 5 persons dying from NCDs is not a matter to snuff about. So we have to use different strategies to get trans fat out of our food supply. So in summary, we're going to be moving to awareness education, reformulation, and regulation in terms of labeling, and of course, monitoring as we go along. My final slide really talks about the partnerships, and in doing so, the acknowledgements. IDRC CARICOM Fund Project, they upgraded the labs and co-funded the assessment. They researched Resolve to Save Lives, the LINKS project, of course, did the lab analysis, and I reported on that. The Bureau of Standards is the one that did the lab analysis. The Ministry of Health and Wellness through the NCD committee and also the Food Industry Task Force were partners in this. My own university supported me while I did this. The National Health Fund is going to help with education and awareness. Scientific Research Council will be doing the reformulation and training. This, of course, is if we get the resources to do all of these things I'm talking about. And the Healthy Caribbean Coalition and NGOs in Jamaica, like the Heart Foundation and so on, they help quite a lot with dissemination of information. PAHO and WHO also helped with technical advice with the lab analyses and also the interpretation of the data. And that ends my presentation.
Wonderful.
Marissa? Okay.
Yes. Thank you so much, Dr. Henry, for that wonderful presentation. Now we are going to open the floor for some Q&A. So thank you to all 3 of our presenters, Dr. Nalika Gunawarden, Dr. Epi Najume, and Dr. Fitzroy Henry. So now if any participants have any questions, if you look at the bottom of your Zoom screen, there's a Q&A button. Feel free to type your questions within this Q&A box rather than in the chat, so we can all see the Q&A questions and go through them together. And these questions could be for any of the three presenters. This opportunity is for all presentations to be, this is an opportunity to ask questions about all the presentations that we just saw.
Seems like everything was crystal clear.
Yeah, really, you did a wonderful job, all of you, with such comprehensive, informative presentations. We have some, so in the chat, some people wrote excellent presentation, very comprehensive. So good job to all three of you. I actually do have a few questions just to get this Q&A started. So I'm going to start with Dr. Nalika. I have a question about your project. Was there any, of course, we know when trying to implement sodium reduction policies, sometimes there's pushback from industry, as industries can sometimes have some financial struggles when trying to implement those substitutions. So I'm wondering, did you personally experience any industry pushback against your project? And if so, we'd love to hear some information about that.
Yeah, thanks, Marisa. Obviously, we had so many industry pushbacks, especially for to enforce the label regulation. They made constant representation at the minister's level, trying to push back either the dates of implementation, and they had the excuses saying they had already printed the labels and also spent so much on having the labels printed for 3 years into the future, or else the other constant effort was to change the levels of amber and red salt, sugar, also fat content. Regarding the reformulation, so those were the main issues. The reformulation, actually, we just had one advocacy meeting with the restaurants, the key restaurant owners, which was quite successful. And as one of my other colleagues who presented informed, they were also unaware of this, even on the connection between salt and ill health, the restaurant owners were unaware. And at that very first meeting, they were all enthusiastic to support health by reformulating. So as I presented, it was a stepwise process. We are yet to go back to them with our results and our training manual and our suggested voluntary target. And we will see next year how they would respond to us on that. Thank you.
Marisa, can I follow up, Marisa?
Of course, of course.
Yes, I'm glad to hear that you're able to overcome the pushbacks. But if you want to implement the front of package labeling in Sri Lanka, do you need the government to approve it? How does it work? Let me tell you, in the Caribbean, the government has to approve. In fact, the CARICOM region has to approve it. So even though we have academia supporting it, the NGOs supporting it, we have the private sector against it. And unfortunately, the government says, hey, we're not implementing front of package labeling. So we have, so how does it work? Because right now we're at a standstill because the majority, and of course, the private sector influenced some of those voters. So we are now trying to see if we can resolve this in some way, but we're fighting a losing battle. How did it work in Sri Lanka? Do you need the government support to fight against the pushback and say, look, we hear you, private sector, but we're going ahead with it? How did it work there?
Thank you. Actually, it is a totally government-led process, because it has to come as now we have the Food Act of Sri Lanka, which was done in 1986, and all these actually these are regulations that are added on to the existing Food Act. So when the front of pack label was added on as a regulation to the Food Act in 2019. So it becomes legal, and there are food and drug authorized officers in the country who could take legal action on anybody who violates these regulations. Of course, at the beginning, the government would give 6 months grace period, though till this is enforced and monitored, and thereafter they are liable to get prosecuted if they don't comply with the regulation. And I'm happy to also tell you, we in Sri Lanka also is bringing in a trans fat regulation. It's been drafted, and very soon we will bring in the trans fat regulations, banning any food which contains more than 2% of trans fats to be imported or sold in the country. And that's another regulation which will be added on to the Food Act.
Thank you. Thank you very much for that.
Thank you so much. Now I'm going to move on to some other questions we have in the Q&A. Dr. Andrew Moran asked in the Q&A, congratulations to all of the projects and presenters. For the Cameroon project, what was the experience of the health workers with using the hypertension treatment protocol? Did patients have to pay for their medications in the program?
Thank you very much, Andrew, for that question. Can you hear me?
Yes, we can hear you.
Oh, great, thank you. During the project, the pilot phase, we conducted monthly supervisory visits to the pilot sites, to the 5 sites, and asked the health workers about their experiences. And indeed, many of them were very happy. They felt some kind of relief because it was a 1-page document that they could easily refer to and just see the name of the drug and the dose and what they needed to do in terms of titration schedule. So it was a big relief for them, and all the health workers we surveyed liked the protocol. Unfortunately, we have very our insurance schemes are not well developed here, and in this case, the patients who were surveyed, or the patients we follow up in our health facilities, pay for their medicines out of pocket. I don't know whether that answered the question.
Yes, that did answer the question. And that also leads into another question we have in the chat, which is also geared towards the Cameroon Baptist Convention Health Services. Did all 5 health facilities use the same hypertension medicines?
Almost, because within the CBC Health Services, we have a central pharmacy that procures medicines and distributes across our network of facilities. And so majority of them use the same medicines, but every once in a while, when a facility runs out of a particular medication, they'll probably just have to buy locally. And this happened in one facility where they bought amlodipine locally, and when they ran out of it, and unfortunately, we had patients complaining of pedal edema, which is a known side effect of amlodipine. But in this case, the patients had been taking amlodipine before, but when they took this particular brand, they experienced more edema than they had ever experienced than with previous brands. So these were a few cases where individual facilities got the medicines from elsewhere, but generally, all our facilities get the same medicines from the same source, our central pharmacy.
Thank you so much for clarifying. It looks like this question is geared to all 3 presenters. Are there any publications from your work? Thank you for presenting. So we can start off by asking Dr. Nalika, were there any publications from your work?
Actually, we have 2 manuscripts, one already reviewed and under revision, and one being reviewed. Those are journal articles, but other than that, we have two two publications which are already included in the WHO IRIS database repository, in fact. So which I can actually share.
Yeah, it would be wonderful if you could share that. And this goes for all presenters, if you have any resources that you've created within your projects that are available to the public, I'm sure our links members would be really eager to see those publications. So feel free to share those with me afterwards and I can disseminate those widely. Next, I will ask Dr. Epi, what are any publications from your project? And if so, we'd love to hear about them.
We are working on two publications at the moment. The first one is to describe the entire protocol development process, which is almost done. And we're also working on another manuscript that is on the reporting or highlighting the results we found in the surveys we conducted. But once they are available, we'll share with the links community.
Fantastic. Dr. Fitzroy,
yes,
would you like to share?
Yes, we submitted one paper to the PAHO Journal, the challenge of bad fats to healthy eating in Jamaica, something like that. And that has been received under review. I'm waiting for comments. And we're planning to, well, I'm currently writing another one on the labeling issue, because I think that's a very important one. You know, what we found in terms of what is on the label and what we found in the lab, not only for trans fat, but other fats as well. It's amazing the discrepancy between what's on the label and what we find from the lab results. And, you know, when we talk of front of package labeling, we have to start with the nutrition facts panel, because that itself is not accurate. So, and the front of package is based on the nutrition facts panel. So I think that publication is going to present some quite interesting findings on what's happening in Jamaica, yes.
Well, I just want to say congratulations to all three of our presenters for having your research published and being in the process of having your research published. It is really exciting to see that your findings from your links projects have translated to real scientific implications that will be shared widely with not only our links community, but also these worldwide journals. So I want to just really take a moment to congratulate you on this incredible work and research you've been doing. We have a few more questions in the chat. This question is for Dr. Epi. Could you briefly explain the slides on the different guidelines and the use? And also, could you share the protocol you presented to the Ministry of Health?
Okay, thank you very much for these questions. This slide, I don't know if we can have that on the screen, but that particular slide with the different protocols simply represents the different options that we ask in the questionnaire. Like we ask the question, which protocol, if any, do you use for managing hypertension? And those were the various options. And we asked the same question at baseline and at end line. And you can see that from the baseline, I think it's the previous slide before this one.
This one?
Not this one, the previous one. Yes, this one. Yes. So you can see from all these protocols are options that were asked in the survey, and the responses, the bars represents the responses, the red bars indicates responses at end line, and you can see the differences in terms of use between the baseline and end line. And the new protocol was denoted as order in the baseline. So what we told the respondents was, okay, if you are using any other protocol that is not mentioned here, you have to listed, and what was listed was the newly developed protocol. And of course, there was a general decrease in the use of the others as time went by. I would like to also note that the survey participants were not exactly the same. The majority of them were the same, but during that 6 months period, there was some movement within these facilities. So it's possible we did have some participants at the end line who did not take the baseline survey, but these were very few. I think we can move on to the next slide that has the protocol. So this is the version of the protocol that we shared with the Ministry of Public Health, and which is going to be included in the National Cardiovascular Disease Guidelines that's under development. I don't know if there are any specific questions on it, but we can see medication names, doses, titration schedules, when we should refer for specialist care, and also laboratory tests, both basic and complementary.
Thank you so much for talking more about the protocol and elaborating on that guideline. Really appreciate it. So it looks like we have a hand raised by a participant. Looks like Rebecca Sen Yonjo, I apologize if I mispronounce your name. You have your hand raised. Would you be able to type your question in the chat if possible? Like to keep it to the, or I apologize, type your question in the Q&A box. We'd like to keep the questions coming from the Q&A box. So if you have any questions or comments, feel free to drop them there. In the meantime, I have a question for Dr. Fitzroy Henry. So I know you mentioned one of the next steps is raising awareness of the problems and risks of trans fat among food manufacturers. So I was wondering when you're going about that, what is your strategy to educate food manufacturers? Because of course we know that the industry can often be opposed to eliminating trans fat.
Right. As I mentioned in the presentation, we are allowing the Ministry of Health to present to the manufacturers the information that we found in the lab. Okay, because to this day we haven't done that, because the idea is not to blame and get to name and blame or shame. The idea really is to get trans fat out of the food system. So this would be done individually to the manufacturers so that they can see the need to come to training for reformulation. So that's the strategy that we have right now. We hope that when they see what is in their products, they will come, and we are developing a program now with the Scientific Research Council, and they have a mandate to help companies, particularly small manufacturers, to reformulate, not only in trans fat, but in other ingredients as well. So that is the plan. One, to inform them, two, invite them from the ministry, invite them, and have a program of reformulation for those who attend. I do hope that they will attend. We do talk with them, and I think they are pretty keen, but we'll see what the feedback will be early in the new year. The challenge we have now is with the COVID protocols, because the lab size that we have can only take 10, maximum 12 to do the practical demonstrations. So if we're targeting the 70, it's going to be quite a challenge to get all of them, trained. But that is the general plan at the moment.
Thank you so much. And I apologize for the background noise right now on my end.
I didn't hear anything.
Dr. Epi, it looks like you have your hand raised. Would you like to unmute yourself?
Yes, I have a question for Professor Henry.
Yes.
Thank you very much for your presentation. Well, I'm very interested in it because we are in the process of elaborating, we're conducting the project now to develop policies for trans fatty acids regulations in Cameroon. And I wanted to ask you, how did you...
Not hearing.
I don't know, survey all of them, or how did
Sorry,
you select?
I lost you for a few seconds. Could you repeat the last part?
Yeah, I was asking how you surveyed or how you selected the producers and distributors of products containing trans fatty acids.
Right. Not the producers. We just selected the products we know from literature that are likely to have trans fats. Okay, so the 296 were those that were likely to have trans fats from the literature. Okay, when we do sugars, for example, we will do many more beverages and so on and so on. So it's a difference in the selection of the sample, depending on whether we're going for salt, whether we're going for sugar, or whether we're going for trans fat. So the 296 was, targeting those that we know are likely to have trans fat in them. Yes. But we didn't go to the manufacturer. We just went, we just took products off of the shelf. Okay, took their labels, took their samples in the various protocols that we have, and then take them to the lab and get them analyzed. So we didn't contact the manufacturers at all. This is commonly consumed foods from off the shelves. Okay, so that is what the Bureau of Standards would be doing when they're doing the monitoring further down the road.
Okay, thank you.
Welcome.
Thank you so much. Do we have any other questions from either participants or our panelists? I'll give it a minute for anyone to share their final questions and thoughts in the Q&A box. Well, if we have no further questions, I want to open up the floor for just any final thoughts from our guest speakers. If you want to share just a quick few sentences about your project, just what you want our Links members here to take away from your presentation. If you have nothing else to add to your presentation, there's no pressure to elaborate further, but just want to offer this opportunity if there's anything you think would be the most important key takeaway from your presentation. We could start off with Dr. Nalika.
There's just one point which I presented also, that one of the key and valuable interventions we did, that National Low Salt Challenge. Actually, the concept I picked up from participating in a webinar like this from India. They presented, and thereafter I got connected with them, and with their details of design, actually we were able to design our own. So I want to thank them and also tell the participants that, these webinars are so very useful for such opportunities. Thanks to you also. Over.
Thank you so much. And I'm so glad to hear that you received inspiration from a webinar like this. That's really the goal of having these very interactive, engaging conversations. We want to learn from each other and take the challenges and achievements from our respective projects to hopefully apply them to a more global scale. So thank you for sharing that takeaway. Next, Dr. Epi, would you like to share any final thoughts you have?
Yes, thank you. First, I would like to start off with thanking you, Marisa, and the rest of the Links team for setting this up and giving us opportunity to share our work and equally learn from colleagues. It's been very enriching for me personally and professionally, and I think after this, I'll try to reach out to Professor Henry again for even more in-depth questions about their project, because it's really impact our own work here. And equally, to say that having a one-page stepwise drug and dose specific protocol it's probably the game changer in terms of hypertension care. And at this point, the ministry is planning to fund some aspects of hypertension care, and they're going to base that on this protocol that we have developed. And so I would like our viewers to maybe in their various corners push for this kind of protocol to be in their own countries or in their areas of work, because it really saves lives in terms of standardizing care, making sure everyone is treated according to the current evidence available and just with what's available. Thank you very much.
Thank you so much, Dr. Epi. And I'm sure that is also an important lesson that we take away, as I'm sure a lot of you know about the updated WHO protocols for hypertension care, the new guidelines that have just come out, where they emphasize the importance of task shifting and patient-centered approach. So I know that that definitely ties into the work that you've done as well at Cameroon Baptist Convention Health Services. So thank you very much. I'm also going to hand it over to Dr. Fitzroy for any final thoughts and any takeaways you'd like to share.
Yes, thank you, Marissa. First, Dr. Epi, you have my email on the list that Marissa was sending to us, so you can link with me. I will link with you and anybody else, in fact, and we can share the experiences. It's, you know, in a 10-minute presentation, you can't give all of the challenges that you face, but I think it's important to, we talk about what the objective is, we talk what the results are, and we talk about what we're going to do, but there are lots of challenges behind the scenes that you need to be aware of, and I'm going to share those with you offline, okay? So that is great. I, like you and others, would like to thank Resolve to Save Lives and the Links Project for supporting. As I said at the beginning, this was a kind of a dream come true in terms of getting some information on trans fat in Jamaica, at least. I'm a Caribbean person, right? So I'm very concerned about the lack of information in the other Caribbean countries. And these results actually are forcing other countries in the region now to strengthen their laboratory capacities. And we're trying to do this through CARICOM so that they can do these kinds of analyses as well to find out what is happening, to meet that Port of Spain declaration I mentioned in 2007, so we can move forward. One specific thing I want to mention, and Dr. Epi should be aware of this. You know, we found you know, trans fat in several foods and so on and so on. And many of the labels say trans fat free. But we need to be aware that in some jurisdictions, trans fat free is allowed on a label if there are small quantities of trans fat in the product. So it is not totally free. For example, if it has less than half a gram in one serving, manufacturers are allowed to say trans fat free. PAHO says, no, we need zero trans fat, okay? And I think the reason for that is because it's cumulative. You know, you eat a donut and it's below the threshold. Then you eat some fries and it's below the threshold. And then you eat some confectionery, it's below. But when you add it all up, it gets, you know, to a very high level. So this issue of trans fat free being allowed on the label is something that we have to discuss here in Jamaica and the Caribbean, whether we will allow it or not. I know the manufacturers would love to have a trans fat-free label with small amounts of trans fat in it. But as I said, with the accumulation of it, it creates a health risk. So that's just a little technical aside that we can discuss in depth offline. But right now, if I had to recommend, I would recommend 0 trans fat, which means not trans fat free, but actually it must have absolutely no trans fat, because as you know, there is nothing good about trans fats. Okay, so those are my final comments. And I wish all the other grantees, I guess, who are listening, the best of luck with their projects. And I look forward to participating in future webinars and hearing about the successful interventions that you're doing as grantees from Links. Over and out.
Wonderful. Thank you, Dr. Fitzroy. And it's so exciting to know that your work has inspired other laboratories in Jamaica and the Caribbean to be doing similar work. So congratulations for helping to spark that, that research. So I'm going to be closing it out now. First, to our 3 guest speakers, Dr. Nalika, Dr. Fitzroy, Dr. Epi. Thank you so much for sharing these updates with the rest of our Links community. We applaud your progress and the accomplishments on your projects, and we are excited to learn more about the research and the publications you will be putting out. To our Links members who have attended, thank you so much for coming and watching this insightful webinar. We hope you found the takeaways from these Links projects to be relevant to the challenges you've encountered within your own work. Lastly, if there's any ideas for future Links webinars, whether you have a topic you'd like to hear or any guest speakers you think we should bring, please let us know. We really love having active participation from our Links members on planning these webinars, and we're interested in helping to have you be a part of this webinar planning process. So a recording of this webinar will be posted to the Links website. Please reach out to me if you have any questions or concerns. I'll put my email in the chat right now. Otherwise, we hope you have a great day, and thank you again for joining us.